Professor Cornelis is going to present his experience when using STRUT. We may have Dr. Ahuja joining, but is actually in the operative room. So unfortunately, he may be late or maybe never show up. We will see. So thank you, Dr. Cornelis. We listen to you and your experience.
Okay, great. Thank you for the invitation. So I'm going to share my experience about STRUT, which started like almost 10 years ago now. So a lot of things to explain, but I'm going to try to review mainly some cases we performed recently at MSKCC in New York. And so, as I said, I'm working at the MSKCC, and so it's a cancer center. So today I'm going to focus my presentation on those patients having vertebral compression fracture and who were treated with STRUT. So I have some disclosure, including I'm consultant for prevention. So here's a plan. We are going to review 3 cancer patients who had STRUT implantation when 1 or 2 pedicles are compromised. And we are going to review the case itself, what we can do in terms of technique, and the outcomes. And also, we are going to review the results of the prospective study we published some time ago about the first clinical trial on STRUT. So to start with, probably we should think about why STRUT could be useful for cancer patient. And so patient having vertebral compression fracture related to cancer. Of course, they could have some osteoporosis and having or also radiation-induced compression fracture, but it's mainly going to be focused on cancer patient with metastasis involving bones. So why STRUT? Well, when I don't know if you are familiar with this, but when you are doing kyphoplasty or vertebroplasty on those patients, the bone is compromised, and there is always a fear of having a serious cement leakage and adjacent fracture on these patients. Life expectancy is already compromised, the quality of life also. So what we don't want is having symptoms related to what we are doing or complication, etc. So in a way, it could be interesting to use implants because it could provide some stabilization by itself, the implants. And I'm sure you're familiar with STRUT, but we can review this. And also going to drive the cement deposition in a compromised bone. So that's a rationale of using this. So what is very interesting and that Cécile developed since some time now is using these implants in peak is going to share the load of the entire vertebral body with the posterior column. And from this, we were thinking that it could be useful when the pedicle is compromised, because there is not much intervention feasible for these patients. Obviously, they could get surgery, but when you have a patient has mets everywhere, it doesn't make a lot of sense to having this extensive surgery. So we were looking at this, if there is a room for using the STRUT to obviously stabilize, but also stabilize the pedicle and see if we can get some relief and what would be the outcomes. And clearly it's a niche because kypho or vertebroplasty cannot address this. We can do kind of building a new pedicle with some cement, but it will never, it could, firstly, in terms of mechanical um, point of view, is going to is not great because it could break, and having the disease growing around, that may compromise also the bones around, and then having fracture. So having something driving the cement deposition and helping to stabilize this area make a lot of sense. And of course, the goal is not to place a V-strut. We don't really, Cecil really want this, but and I don't understand this. But at the end of the day, what we, and I'm sure Cecil and know want to also doing this is, we want to provide some relief to the patient. So it's an early experience, so we need to evaluate this, and I'm going to show you some of the results. So you all know what is a V-strut. So it's in peak, it's very well tolerated by the body. We cannot see it, but there is some markers to allowing us to see the tip and the back. So we can very nicely place the device and doing some pretty good job with the device itself, thanks to its design. So it's transpedicular. We can, I mean, in the lumbar area, we are using a pedicular access, and then we're using PMMA cement. We could do a kypho before, we could ablate before, and then place the implants. There is no issues doing this. The lateral holds are helping us to deliver the cement adequately in the vertebral body. And of course, we already mentioned the benefits of doing this kind of implants. So I'm going to start with something you can cite. And this is the study we published like some time ago. It was relatively tricky to do this study because it was very early and it came up exactly at the same time as the COVID. So that's the reason why we have only 9 patients included in that prospective study. So it was a multi-center prospective clinical trial on patients with cancer and osteoporosis, with relatively not very aggressive fracture, Magolo A1. And we reviewed that cases, and we had this 100% success to implant the implant. And the time was a little bit more than an hour, but it was highly variable depending of who was doing the cases. We had some leakages, but it was asymptomatic, and at that time we were using um, uh, I would say a mid viscosity cement, explaining why we had these leakages, but it was not very significant and absolutely comparable to what we observed in kyphos or vertebroplasty. We had one migration of the implant, and the reason was because the implants was mobilized before waiting enough time and waiting for the polymerization of the cement. That's clearly a technical issue. And then after reviewing the different step, it never happened again to this operator. And then we never observed complication from this. We had a follow-up of more than 6 months, and we never observed fractures, adjacent fracture just above or below the implants. What was very interesting, even we included some cancer patients, And we had some improvement in the pain, and that was very promising. So, of course, this is a very limited study, but it was prospective and demonstrating some good outcomes after this peak implantation. But what I want to say about this study is we were not looking at the pedicles. We were looking at the feasibility of placing these implants. So that means what I'm going to show you after is not exactly the results of this study, but some new development that could help to further develop the technique. So I'm going to show you 3 cases, and we're going to start with this one. So it's the first case. It's a lady with lung cancer, with a metastatic lung cancer. A lot of disease everywhere, and this fracture of L4. And there is a lesion involving the right pedicle. And instead of doing just a kypho, we were considering the V-strut. So this lady was absolutely fitting for the procedure. So general anesthesia, she had a lot of pain. And then, as always, what we do before the procedure, we are reviewing the CAT scan or the MRI. We are carefully evaluating the fracture and the pedicle, trying to plan what is going to be the diameter of the implant of this strut and what would be the length. We currently placing 2 implants in each pedicle, and that's the plan for all the patients. And I'm going to repeat this several times, but this is a recommendation from Cecile. It's about where we deliver the cement. So we start to deliver the cement centrally. So we need to check what's going on in this area to feel the bone, trying to avoid the leaks. And when the bone is compromised, as in this patient, we have to be very careful with this. I mean, very careful, of course, but we were not worried about it, but we were trying to think about if we start in the middle where the lesion is, what is going to be the cement deposition? Because obviously what you think when you are doing this kind of case is to inject the cement where there is still some bone, because if you inject where there is a lytic lesion, then you might have the cement going everywhere. So yeah, we were thinking at this time where we should deliver the cement, but then we figured this and we follow the rules of starting to inject in the center and then see from there. So this is the procedure. So if you look at the lower left is when we place the needle. So I'm using a bull's-eye view of the pedicle view. So it's like the Scottish dog. You can see on the left side, right at the head of the Scottish dog, placing the torque. Then we moved lateral to place the different tools, helping us to proceed. So I don't know if you're familiar with the different steps. So firstly, we place a torque, then we place a K-wire. Then from this, we are placing a cannula to prevent injuries in the soft tissue. We call this a dilatator. We place this by the bone on the posterior elements, and going to hold this firmly. So the K-wire then is stay there, but we remove the inner part, just leaving the protection of the soft tissue. Then inside this, we're placing a drill, we're drilling. You can use different drills. There is one 4.5, one 5.5, one 6.5 millimeters, depending on what kind of implants you want to place. Sometimes you can start with a small one and then increase, like when the bone is not really compromised, but when the bone is highly compromised, you can go straight to the largest one, and again, largest compared to what you plan in advance. Then you remove the drill, and then you place the implants. So this is a third image starting from the left. You can see the implants by the marker at the tip. Then you do the same thing on the other side, so that you obtain the fourth image. You can see two markers inside the vertebral body and the two other markers close to the dilatator. And on the AP view, which is a fifth image starting from the left, you can see the implants. There is still a K-wire in place, but then we are going to remove it to start to inject. And this is what you obtain on the right side. So upper right, it's a lateral view with the cement deposition. And then the AP view, and then the final images. You see lateral and AP view. So what we can learn from this is the bone was compromised with a lytic lesion on the right side. It's like it's what you see on the right. It's and compared to the left there is bone, so you see this feeling of the trabeculum of the bone on the left side, but it's not exactly the same on the right side. And because the cement went to the lesion, but the good news is, even if we were like, again, not very worried, but concerned about how is going to be the cement deposition. The cement deposition was exactly where we, around the implant. And what is very interesting is, in fact, these small tiny holes inside around the implant allow very nice cement deposition, even in the lytic area, without creating some leaks. And that's very cool, very safe. And in terms of mechanical constraint, it's probably a very good thing that having these implants in the center of a nice cement deposition around. So that's the result of on this lady. So to explain the outcomes is she still alive. She has an active disease, and she was treated after with radiation, trying to minimize the tumor growth. She developed between this procedure and the radiation an epidural with some sciatica. So she had a resection, a laminectomy in this area. And why I'm mentioning this is because the surgeon didn't complain at all about the device. So that's good. They were like thinking it was quite smart to have stabilized the pedicle, allowing them to do the surgery and with some decent outcome for this lady. Yeah. And at the same, just to mention, at the same time of this implantation, I also did a fixation of the sacrum. And overall, the procedure took like an hour and a half or something like that. And we were doing this as outpatient. So it was a decent success for this patient. So that's my first case. The second case is similar, but a little bit different. So the second case is a patient with a prostate cancer, again with a pedicle injury of L1 on the left side this time. But this patient also had L2 fracture, as you can see on the sagittal view of the MRI. So the plan was to do the V-strut of L1 and then just a vertebral kyphoplasty of L2. Because on L2, the pedicles were looking good. And we were not ready at this time to do 2 levels with V-strut. So I'm going to show you the procedure on the next slide. So this is the result. So you see on the lower left, on the L1, you see the implants and before injecting the cement. And L2, you see just the needle to perform vertebroplasty. The second image on the lower part is when we start to inject on one side, and then further and further the others. And what you can it's nice to see on this slide that the cement deposition is quite dense. You see, it's a very dark cement in the lesion with the implant, and there is no leak. It was nicely delivered. When you look at the results on the final results on the right side, so the upper one is just after the cement deposition. So you see kind of shadow of the implant and surrounded by the cement. So this is the implant here and surrounded by the cement. What is interesting here is the difference between L1 and L2. L2 was just vertebroplasty, and L1 was so this V-strut implantation. And you see the cement deposition is way better on L1 compared to L2, with way more cement from one side to the other, from the superior end plate to the lower end plate. And that's very well known that is a better result than this one, where we have 2 parts of cement. It's going up, down, right, left, but it's not great compared to this one. And then when you look at the sagittal view, you see the pedicle are clearly completely reconstructed by the peak implants plus some cement inside, with a very dense and vertebral body full of cement, with just a vertebroplasty where there is a less homogeneous deposition of cement. So that case is quite cool. I mean, it's helping us to develop the rationale of doing these implants. I'm a really fan I really like implants because I think it's helping us to standardize the practice, helping us to do a better job than just taking a needle and injecting cement. Of course, it's a little bit more complex, not much longer, but clearly helping us to do probably a better job. So that's why I was showing you this case. And the results were good. The patient died from the progression of disease, but nothing related to the spine, and he never complained again of his spine during the follow-up. That case, my third case, was just performed like 3 hours ago. So it's a 45-year-old man with some mets in the spine, a lot of mets, and he developed this fracture of L3. He was in so much pain, was barely moving, but what was difficult for him, it was a very high BMI, but like a very big guy. So I was planning to do a kypho, but when I saw the fracture and thinking about, I was like, okay, there is when you look at the CAT scan obtained during the procedure, it's a convexity. I was looking at the images and I was like, oh, the bone is completely compromised everywhere. The pedicle look terrible. on both sides. And we probably need to do more than this. So after measuring the pedicle and the length, as I was mentioning, we drill, we place the needle, and you see the results on the lower part. You see, so first on the left lower, you see the implants right in the middle. And then after we filled with cement. So the cement deposition is not as great as the other cases, but the bone was really compromised. And we were able to fill the vertebrae. It's a mixed lesion, not completely lytic, and we were able to fill the cracks with the cement and placing the quite nicely as the devices in the cement without leaks. And the good news is the patient already mentioned some improvement. He had some soreness, probably because of the access, and it was very deep. All the tools were fully inserted in the patient body, but we were able to do that case, and hopefully it's going to help the patient. So in terms of technical pearls and pitfalls, the cement control, I think, is improved by using this kind of device, reducing the risk of leaks. In terms of implantation, well, we just need to follow the different steps and placing adequately the marker and the devices, allowing us to do a good job. And what we need to expect, what we can expect is based on the publication we had is we can see some leakage, but likely if we are using some high viscosity cement, it's going to be less than this. And what I would like to emphasize also is to take time, no rush, inject slowly, and we obtain some good results from this. So outcomes, I already mentioned them. What we can take in terms of take-home messages is we can do VSTRUT in many indications. It's very promising with very few adjacent, very few complications. I'm not sure a leak is a complication, but we never observed adjacent fracture, which is good at this time. So future and conclusion, we can do VSTRUT in this cancer patient, including the pedicles. We probably improve the standardization and cement control. It's feasible. It could be performed at the same time as other levels. And we can do thoracic spine. I just show you some lumbar currently at this time because we were focused on the lumbar area, but we can do T-spine. And there is more to come. And I would like to thank you, and I will be happy to answer all your questions.
Thank you, Dr. Cornelis. Does someone have any question for Dr. Cornelis?
Yes, I have a question. Do you prefer Stryker's Vertiplex and Autoplex mixing system?
Yes, you can say yes.
Or I guess rather, are there other PMMA cements that you have tried that you just prefer Vertiplex over one or the other, or?
No, yeah, I prefer the Stryker cement. Yes.
Okay.
We tried many of others, but I prefer but it's clearly and fully depending of the operator. But I think it's a quite yeah, it's a quite a good cement.
Okay, thank you.
Any question from the audience? I have a question regarding the imaging. What is the best imaging you will use to identify that you have a pedicle involvement and that will allow you to decide that
Good
this
question.
threat is a good product for your
I
patient?
think MRI is very helpful to see if there's an edema, and that's quite a standard to evaluate a patient with cancer on the spine. But I really like the CAT scan also because it can help us to better assess how is the bone and to see the fracture. Because with the MRI we can see the edema, but with the CAT scan you see the bone. So sometimes I don't have the CAT scan, but often the patient with cancer have a lot of CAT scans, or that should not be an issue. But as I'm doing these procedures under cone beam, I can still have some bone evaluation at the time of the procedure. So often if there is like, I always start with the MRI, and if I need something, I will obtain my bone images with a CAT scan. But I would recommend to do an MRI every time.
And when you identify the patient with a oops, someone is coming. Someone
No, the
asked a
question
question.
was, is there a difference between the striker and V-strut? So I guess the striker, the spine jack. So if you read so in cancer patient, if you, I published that paper on the spine jack. I think there is a major difference. It's because with the spine jack, you need to increase the pressure when you deliver the jack. You increase the pressure within the vertebral body. So V-strut is absolutely not creating any additional pressure except the drilling, and that's a major difference. And I really like, I have to say, I really like the spine jack, but I think in cancer patient, V-strut has probably a room compared to the spine jack. Sorry, I interrupt you. You had another question.
No, the question was about what is the time between the time you identify the patient as a vertebral fracture and the time you will treat the patient?
Well, like let's say the patient we did today, I saw him 2 days ago, and then so I would say as soon as you have the devices, and it's quite nicely, the packaging quite nice where you can just select the implant you need. It's probably enough to have like 1 or 2 days to proceed. Of course, I mentioned this to the patient, and we need to consent them. But yeah, it's good. Yeah, it's not probably not big deal.
Maybe the question from Dr. Josma, he also mentioned Medtronic iPhone, so maybe he wanted you to comment on V-strut compared to kyphoplasty. Can you
Yes,
can
that's a
you
good
comment on
question.
that? Yeah.
So one question, okay, so this is something we review is if you use a kyphon, so kyphoplasty, the rate of adjacent fracture is more than 10%. And with
It's
V-strut,
25, I guess, according to the literature.
all right, okay, it's more than 10, okay?
Yes, Sarkos study
I
mentioned
didn't say
25.
10%, more than 10.
Yeah.
And with V-strut we don't. So there is probably something here. Of course, we don't have any comparative study, so it's just reusing the literature. But there is probably something here. V-strut is the only one addressing the transfer of the load towards the posterior element, so that's probably explaining the difference. But the numbers are not the same. So currently, it's hard to compare, but I think it's two different things. There is kyphos and there is V-strut and there is spine jack. All of them are different. So we cannot compare bananas and apples.
So clearly, V-strut will be used when there is a pedicle involvement, but if there is no pedicle involvement, in the second case you have shown, So it was 2 levels, one with a V-strut and the second one with a kyphoplasty. If you had to do this case today, will you do the same, or will you use a V-strut on both levels in order to have, as you said, the nice stamen distribution? And
Yeah, that's a good question. That's a very good question. I would retrospectively, I probably should have done both levels with V-strut.
Okay. Any other question? I have another one regarding anesthesia and any medication you will give to your patient to make sure they have no pain. So pain relief can come from the use of cement, but so what is the anesthesia you generally use, and do you provide or do you prescribe medication for the pain to your
So
patient
as a
or the specific vertebral
cancer
fracture?
patient are performed mostly under general anesthesia for
Mhm.
their safety and comfort.
Mhm.
They are receiving a lot of medications already, so we are not changing anything in the regimen, but they are still under medication. But slowly, if the mechanical issue is addressed, we can slowly reducing the painkillers and introducing some physical therapy. But there is a bias. It's cancer patients, so there's like highly we're serving high dose of medication often.
And Dr. Calise, I have a question on, I want to say it was your second patient on one of the pedicles was pretty lytic. So you were working on the contralateral pedicle just to create an anchorage, as you were mentioning. Can you explain a little bit of that when you're entering a portion of the bone that's pretty lytic?
Yeah, so when you have a lytic lesion in the vertebral body, you could feel the lytic lesion, but you are going to have leak. And in terms on mechanical, injecting some cement within the cavity is not going to help at all of the stability of the bone. So the way to do it is to access both sides and then trying to feel both sides to obtain um, like we are trying to feel the vertebral body and to avoid further collapse and while allowing some stabilization and then some relief. So that's the reason why we need to access both, and we cannot leave one alone. And so that case was quite nice because the pedicle was compromised and the lytic lesion was clearly on one side.
Yes.
And instead of accessing, like, let's say, unipedicular access, you will deliver cement in the middle, but in the middle it's a mix of between some bones and some lytic lesion, and then the cement is going to fill the cavity, not the cement, and then we are going to create a mess. So that's why I like to have the V-strut and accessing this kind of lesion on both sides to just try to deliver the best we can the cement.
Thank you. And we have a question from Dr. Hosma again. What in the setting do you recommend V-strut to be performed hospital, ASC, physician office, and is it covered by insurance?
So I defer this to
Yes,
Cecile to answer this
we can
question.
answer that, yes. So actually, the procedure, the best place to perform this procedure based on the reimbursement and coverage by Medicare, it's hospitals, could be in physician office if the operative room is set up to perform this kind of procedure. But unfortunately, in surgical centers, the reimbursement is very low, and the V-strut pricing is higher than a regular kyphoplasty. So unfortunately, we cannot do a V-strut procedure in surgical centers because of the reimbursement. But that should be the best place to do it. Not in cancer, but for osteoporotic patients, that should be the best place. But financially speaking, it doesn't work.
So it is
And
the
maybe,
hospital setting and an OBL setting are the
yeah.
two preferred settings and locations for a V-strut procedure.
Dr. Cornelis, you had a past experience with osteoporotic patients. Can you talk about that a little bit? What is different? Is it easier? Did you see pedicle involvement in osteoporotic patient? Do you?
Well, the pedicle, the story of the pedicle is quite new, okay? Because at the beginning of the story of V-strut, we were not allowed to do it. So
That's true.
that's for
True.
to answer this question is going to be tricky. So that's about the pedicle, but about the osteoporosis, it's working exactly the same way. What we need to be very careful is when sometimes the bone is so soft, but with a cancer patient also is with the drill you can the drill is super powerful, so you can drill very easily, and you have to be careful with this. But otherwise, it's the same. I would say it's exactly the same, except you are maybe less worried about having leakage, but it's more or less exactly the same story.
And the benefit in osteoporosis is that the risk of adjacent fracture is
Correct.
higher. Yes.
But you know, patients with metastasis are also with high risk of adjacent fracture. So at the end of the day, it's quite promising results.
Okay. So Dr. Josman is typing
Yeah, we might have
new
another
questions.
question.
We are going to wait for him. Anyone else who like to ask a question?
Okay.
Oh, we wait for Dr. Josman. You can speak on the mic, Dr. Josman, if
And
you
yes,
want.
yes, I was going to say that, Cecile. Thank you. Feel free to unmute yourself and speak, ask any questions. It's yes.
Can you guys hear me? Hello?
Yes.
Yes.
Hello.
Okay, so sorry about
Thank you
that. I
for
didn't mean
joining.
to. Yes, sorry I was late. I was finishing up cases as well too, but thank you for having me and thank you for answering my questions. I was just going to ask a final question if you had any literature that I can share with our oncology colleagues and be able to better describe and I guess pick patients for this procedure. They're very protective of their patients, which I understand already, but I want to be able to let them know like, hey, this is a better option, or this may be something that fits a specific case.
Yes, and we do have literature that we can send you. I can send you one paper in particular, kind of highlighting the patient selection on recent oncology patients treated with V-strut. But we have numerous clinical papers, white papers that I can send over to you that could, compare and contrast V-strut to balloon kyphoplasty, to Stryker spine jack, to any other kind of products out there on the market. Talking about clinical benefits, indications, biomechanics, patient selection. So anything related to V-strut, I can send over.
Awesome. Thank you so much. I'd appreciate it.
Yes.
Any other questions? So unfortunately, Dr. Ahuja is still in the operative room, so he's not going to join. So if we have no questions, thank you very much, Dr. Cornelis, for the presentation today. This presentation has been recorded, so